positive in scleroderma. Anti-Jovan antibodies are seen when there is an association with ILD, arthritis, Raynaud's phenomenon, and then there is another variety of antibodies, and this is the anti-signal recognition particle, and these are associated with cardiomyopathy, and here the patient has a very aggressive disease. And then we have the anti-M12 antibodies, and are almost always associated with dermatomyositis, and they have a good response to immunosuppression. And finally, the anti-synthetase antibodies, which are associated with the anti-synthetase syndrome, which is a very aggressive disease and needs very aggressive treatment. These are the typical EMG findings. I'm running very, very short of time, so I might just breeze over these slides. However, I would like to take a few seconds over here. In polymyositis, the infiltrate of inflammatory cells are mainly within the muscle fascicle, and there is no invasion of the individual muscle fibers and no vasculopathy or immune complex deposition. Whereas in dermatomyositis, the infiltrate is mainly perifascicular and perivascular, complement activation and microinfarcts of the muscle fibers. And the inclusion body myositis shows vacuoles. This is polymyositis, and we can see that the muscle fascicles have been invaded. And here, this is dermatomyositis, and mainly the infiltrate is perivascular and in the interfascicular space. And sorry, this is a very small slide. This is the normal muscle. This is polymyositis, dermatomyositis, and inclusion body myositis, in which you can appreciate maybe the presence of vacuoles and the inclusions. MRI is not usually used in diagnosis, but it can be used to document myositis disease flare, or it can non-invasively direct towards the site of biopsy. The treatment is pharmacological and rehabilitation. In the pharmacological variety, we have mainly steroids, then we have other immunosuppressive agents, and then IVIG has been shown to be very effective. We start with steroids, divided doses of 1 milligram per kg, and then we continue for about 1 to 3 months at least, and once there is normalization, of CK and the muscle strength starts to improve, then we tend to taper by about 20 to 25 minutes every 3 to 4 weeks. And with severe myositis or life-threatening extramuscular involvements, we need to pulse the patient. Then we have a lot of immunosuppressive agents. Combination of methotrexate and azathioprine seem to be very effective in refractory myositis. Cyclosporin has also been used. Mycophenolate has been used and it's been very effective. You need to be a little careful with anti-TNF because alveolitis has been reported in other diseases, and rituximab has also been used. I cannot lay enough importance on the importance of rehabilitation, and Nabila has been through with us very, very elaborately in this respect. So physiotherapy very much goes hand in hand with the pharmacological therapy. Now, a few words about inclusion body myositis. Steroid use is controversial, but studies have shown that when steroids are used, they tend to decrease the enzyme and muscle inflammation, but the muscle strength continues to deteriorate. So a lot of importance has been put on physical therapy. IVIG also has been used effectively, but they have to be used, concomitantly with DMARDs. Then these are some of the extramuscular manifestations. ILD is a very dreaded complication that may decompensate to ARDS, and here we need to take the pulmonologist and the intensivist on board, and we may need to, pulse the patient, and then arthritis tends to settle with steroids and DMARDs. Various drugs have been used for the rash. In soft tissue calcification, which is common in juvenile dermatomyositis, a lot of things have been used, but no treatment has been very effective. These are some of the life-threatening emergencies. Okay. The prognosis may be variable, however, worst outcomes have been seen in polymyositis, including body malignancy associated and ILD associated. These are some of the predictors of poor prognosis, and the take-home message is predictors of poor survival over here is old age, malignancy, delayed treatment with steroids, ILD, aspiration pneumonias, cardiac involvement, and juvenile dermatomyositis with GI vasculitis and sepsis. And with that, ladies and gentlemen, I thank you for your time and attention.